Hi everyone, Dr. Raj here, and I am very excited, what a surprise, because I am always loving new, interesting, and hot topics out there. And today I want to do a combination of two of my favorite things. Number one, cardiology, and number two, sleep apnea. I'm going to talk about, like the title slide states, sleep apnea and cardiovascular disease focusing in adults. I want to actually talk about cardiovascular disease and obstructive sleep apnea. So the first thing I want to do is mention that when we talk about OSA, obstructive apneas, meaning they're often in obese patients. And people always mention, well, why is obesity in itself such a risk factor for heart disease? So actually I put this diagram on the right, and the reason why obesity really predisposes you to heart disease is because of think of the concepts of putting organs in series or parallel. I know I'm going back to the basic science, but what happens is our organs in the body are in parallel. That means it's going to be low resistance, which makes sense because blood wants to flow to every organ. So notice down here where it says skin, muscle, and bones, I mean, all these three are organs and they require blood flow. But let's say someone is obese, which we see in many of our patients who have obstructive sleep apnea, that you could actually put another organ down here called adipose tissue. And if you have adipose tissue, does it need to be perfused with blood? The answer is yes. So by putting another organ here in parallel, what happens to resistance? It decreases. So total peripheral resistance goes down. But what happens to the heart is that cardiac output has to increase because it needs to perfuse an organ that's not normally there. And when cardiac output increases, that means the heart is going to be working harder and harder and harder to perfuse that adipose tissue. And guess what happens to the walls of the left ventricle? They hypertrophy. They develop something called LVH, left ventricular hypertrophy. And is that a risk for congestive heart failure? The answer is yes. And that's one of the many reasons why obesity is associated with heart failure. And that's another reason why, because many people with obstructive apnea unfortunately tend to be overweight, they tend to be obese, that in itself could be a risk factor for heart disease. And it's not surprising that when you have obstructive sleep apnea, these patients are predisposed to having high blood pressure. And when you have high blood pressure, you know that what happens to the afterload to the heart? It increases. And when you increase the afterload, you're going to have to work harder to push blood out of the left ventricle, also making people predisposed to heart disease. It shouldn't surprise anyone that sleep apnea is associated with poorly controlled diabetes. And when you have high levels of glucose circulating in the blood, diabetes is one of the deadliest risk factors for what? Coronary artery disease. So we could have this conversation all day talking about the correlation between obstructive sleep apnea and heart disease. But I wanted to put this second bullet point here, which is, we always associate obstructive apnea with men. But when females are going to be postmenopausal, they have just as high risk, if not higher, than men when we talk about obstructive apneas. And I think this is very timely because of the fact that we know that in women, we are actually underdiagnosing things like congestive heart failure and coronary artery disease. And I'm going to talk about that in 1 second. But new studies have shown that based on biomarkers that we see from myocardial infarctions and heart failure, there may even be a stronger correlation between obstructive apnea correlating to women even more than with men. So this is a slide I'm very proud about, talking about awareness for cardiovascular disease in women. It's something that's very, very important to me. And when we talk about this, women have a higher prevalence of risk factors of cardiovascular disease, including high cholesterol levels, diabetes, hypertension. And it's very important to realize, if you look at the third bullet point, women often have atypical symptoms when it comes to cardiovascular disease than men. So what we classically describe as chest pain radiating down the left arm, it could just be presenting with nausea, it could be unusual fatigue, shortness of breath. And the last bullet point I just wanted to say to pound home the importance of recognizing cardiovascular disease in women is that more than 2/3 of women who die suddenly from coronary disease didn't even recognize the symptoms or had no previous symptoms. That's what we call sudden cardiac death, and it's very scary. So let's go back to correlating cardiovascular disease and sleep apnea. So people always ask me, well, we talked about the physiology of obstructive sleep apnea. We talked about the heart. What's the physiology of what connects them together? So I would say it's going to be two main things, but I'll talk about three. So when we talk about, sleep apnea, the consequences will be seen based upon arousals, based upon hypoxia. And I feel there should be another box here that I could put down. Some of the hormones are going to be released, but I'll incorporate the hormones into the arousals and hypoxias. So I do love this graph though, this chart. It's very, very, it plots out what is going to be the physiology. So when you have obstructive apneas, why do people feel sleepy and fatigued during the day is not because of the quantity of sleep, it's because of the quality, that these individuals are not going to the deeper stages of sleep. They have multiple arousals throughout the night. And you can imagine when you have multiple arousals throughout the night, it's almost like you're sleep deprived and you release many of these hormones. There we go. I'm incorporating those hormones again. So what are these stress hormones? The big one we always think about is cortisol. So you can imagine that when we talk about sympathetic activation, cortisol, epinephrine, norepinephrine, dopamine, all these things are going to be released. What else happens is that many hormones that are secreted during the deeper stages of sleep that are associated with weight will actually not get released or released inappropriately. So there are so many things that happen when you have multiple arousals and not able to get to the deeper stages of sleep. And because of this sympathetic activation, all the stress hormones I talked about, what happens to the heart rate? It goes up. And if you have heart failure, one of the most important things to do is to control the heart rate. That's why beta blockers decrease mortality in CHF. By lowering the heart rate, you get more time during diastole, more filling, but you're not going to get that if you have constant sympathetic activation. Also, things like the renin-angiotensin system is going to be increased. Renin is an enzyme that will activate angiotensin 2, and in some cases go on to activate aldosterone. This is a hormone that makes you retain sodium. And wherever sodium goes, who follows? That's right, water. And many people with heart disease don't need that extra fluid on board. And then when we talk about sympathetic activation, sure, it's going to increase resistance, but let's just keep it simple. It increases the afterload of the heart, the afterload of the left ventricle, making the heart work harder to pump blood out of the left ventricle. And then going back up again, I just can't get enough of this. Because of the disturbed sleep, you act like you're sleep deprived. And nothing good happens when you're sleep deprived. You can't concentrate. You can't focus at work. So decreased mental acuity, fatigue, there's so many things. And then of course, we can't forget being hypoxic. When we talk about oxygen, we always talk about the three players involved: the lungs who bring the oxygen in, the heart that delivers the oxygen, and of course, the red blood cells that carry it. And if you have problems getting the oxygen in, this can lead to decreased oxygen delivery, some ischemia, can lead to inflammation. And if you already have pre-existing heart disease, that that the coronary arteries get only 5% of the blood flow from cardiac output. And if you're already hypoxic, you're really going to be predisposed to things like an MI, like stroke, like mental status issues. And this could be another cause of worsening dementia. And of course, a lot of inflammation around the body. So when we talk about obstructive apnea and cardiovascular disease, I always want to quote studies. And in reviewing many observational studies, they have demonstrated a consistent association between obstructive apneas and high blood pressure, coronary heart disease, cardiac arrhythmias, and heart failure. So I always want to call out the elephant in the room. What's going to be the thing I wanted to mention that I don't want to hide behind is a study called the SAVE Study. So when we talk about cardiovascular disease, there's no ifs, ands, or buts. Is that I feel that if you can treat your obstructive apneas by just breathing in some pressured air through a CPAP machine that I put right there, and it will help you, not get a heart attack or a stroke. It's worth it. I would do it. But there was a study that came out, and it was called the Sleep Apnea Cardiovascular Endpoints, the SAVE Study. And it was a big study. There was 2,717 patients, and they had moderate to severe obstructive apneas, and they had established cardiovascular disease. And I think that's the key point that people don't remember, is that there's primary prevention and secondary. Primary is preventing you from getting that first event. Secondary are going to be subsequent events. Anyways, they followed these individuals for 3.7 years, and they randomized them to being on CPAP versus not. And what they noticed is that despite a reduction of the apnea-hypopnea index from a number of 29 down to 3.7, CPAP was not associated with a reduction in mortality, meaning cardiovascular deaths, including MI and stroke. So, many times, when I do a lecture in front for our grand rounds, many people will bring up this study and tell me, what do you think about this, Dr. Raj? Hey, and it is what it is. It's a secondary prevention study. I think there, like many studies, there's always going to be criticisms of it, but it doesn't hesitate me for a second to identify the people that would benefit from treating their obstructive apneas, knowing that just by wearing a mask, I can prevent a 1 MI or 1 stroke. And remember, this was a secondary prevention trial, but I just wanted to mention it. When we talk about sleep apnea and hypertension, I probably have the most slides about this because hypertension is very, very common when we talk about the United States and around the world. So look at this data. Approximately 50% of patients with obstructive sleep apnea have coexisting hypertension. And what is surprised, it's most elevated, the blood pressure in the morning. Why is that? What's the name of my favorite hormone in the morning? Cortisol. And that's why many people have those higher levels, which tells me you should treat the sleep apnea at nighttime so they won't start off with those high blood pressures. And of course, I believe data for MIs say that most of the MIs happen earlier, closer to the morning. So also it found out that people with hypertension, especially patients with resistant hypertension, have a very high prevalence of OSA. So if you have a difficult control hypertension, chances are that you may have some obstructive apneas. Now this third bullet point is, remember I mentioned about REM sleep earlier, that they found out in this study that if you had severe OSA, especially during REM sleep, that was strongly associated with the incident of having high blood pressure. So why is this important is because when we talk about the overall apnea-hypopnea index, that's looking at the entire night. If you have an elevated AHI only in REM sleep, that we may not consider treating you because the overall AHI isn't elevated and REM sleep is only a small portion of the total view of the night. But that's a hot topic in sleep medicine. What do we do in patients who have a severe apnea-hypopnea index only in REM? And this statement states that maybe we should consider treating them, especially if they have resistant hypertension. So a little food for thought for everyone. So when we talk about some of the observational data examining the history of CPAP on hypertension, they definitely suggest a benefit. They definitely say if you use a CPAP, you'll get some benefit. And many randomized trials and analysis has found that effective treatment of obstructive sleep apnea using CPAP reduces the blood pressure. And the interesting point about this, it reduces it regardless if they're hypertensive at baseline. So depending upon whose guidelines you use to define hypertension, just by treating your obstructive sleep apnea, you will lower your blood pressure. So I definitely want to call out some of the things that people always ask me during my lectures in regards to obstructive apnea and hypertension. Many of the studies didn't really control for the antihypertensive medications well, meaning that did they stop them? Did they continue them? What were they? Maybe it's a combination of certain meds or lack of certain meds that will help patients out. So there is confounding information there. It is also important to realize that most people who get the benefit from using OSA, or not using for treating their obstructive sleep apnea, they had excessive daytime sleepiness. That was one of the things they presented with. And most patients who did not report having excessive daytime sleepiness, they didn't have it, they didn't really find as much of a reduction in blood pressures than in those who do. So I wanted to mention that also. And of course, when we talk about reducing the blood pressure, it seems to be related to the severity of obstructive sleep apnea, meaning the more severe OSA you have, the more response you'll get in the blood pressure. And I also wanted to mention, when we talk about compliance, one thing that you could use to motivate your patients to stay on their CPAP if they use it is that stopping your CPAP may give you a rebound increase in your blood pressure. So I also wanted to say that when we talk about, treating the OSA, most of the studies that I'm talking about have been using positive airway pressure, a CPAP mask. That alternative therapies such as an oral appliance, as you see up here, or even something down here known as a tongue stimulating device. And that's right, that's exactly what I said. There's certain companies have a hypoglossal nerve stimulator, and that's what you see here. It's a little transmitter that gets implanted here, and one lead is connected to the hypoglossal nerve, and there's another lead that's a respiratory sensing lead. Of course, this is not first line. These are individuals where you want to treat, but they are not good candidates for, they couldn't tolerate PAP. They're not candidates for other types of surgery that you may consider this. But once again, alternative therapies in regards to treating the hypertension with OSA hasn't been well studied. So why is this important, especially to a cardiologist? Well, when we talk about guidelines, and I hate to say that, there are so many different guidelines out there. For someone who's an internist, they may be using the JNC8 guidelines. And when we talk about these guidelines, the big thing is what I circled in red are individuals who are older than 60 years of age. That the guidelines, according to the JNC8, state that, hey, it's fine, and you could have, as long as their blood pressure is less than 150 systolic and less than 90 diastolic. And that, of course, raised a lot of controversy about, well, when we think about people who have atrial fibrillation, they're going to be at least 65 years of age, if not older. Most people with sleep apnea are going to be greater than 60 years of age, but according to these guidelines, we're going to accept such a high systolic. So, of course, the American College of Cardiology and the American Heart Association came out with new definitions of blood pressure. And we define elevated blood pressure anywhere with a systolic from 120 to 129, stage 1, 130 to 139 systolic, and stage 2, anything above 140, which is quite different from the JNC8 guidelines. So, of course, I wanted to mention a trial called the SPRINT trial. So the SPRINT trial, which is actually in the New England Journal of Medicine, was talking about being aggressive in patients who are going to be older in age. I believe that these individuals were going to be at least 70 to 75 years of age. They were without diabetes, and they were targeting a low blood pressure around 130. Less than 120. And of course, what did it find? To reach that goal, you need to be on multiple medications. There were definitely side effects from being on these medications, but there was a reduction in some of the endpoints like MI, stroke, and acute coronary syndrome. Why am I bringing this up in this presentation is because, if you can avoid polypharmacy by treating obstructive sleep apnea, then that's only going to benefit your patients. Both, they're going to help out with their sleep complaints, their heart complaints. So especially where we're trying to get their blood pressure a little bit lower based on some of the data from the SPRINT trial and your clinical expertise, this really makes me want to help patients who have obstructive sleep apnea and hypertension. When we talk about coronary artery disease, I put a classic journal article that was in the Lancet, so you could look it up. But there is increasing evidence that severe OSA is associated with an increased risk for cardiovascular events related to coronary heart disease. And this is independent of being obese, independent of the other risk factors. And in this particular study, it was a prospective cohort study that followed 1,651 men. So once again, poor women didn't get involved in this study, what they should, and I told you how important it is, but this was a study for men. And what happened is that people with severe obstructive apnea, meaning their apnea-hypopnea index was 43, they had a higher incidence of fatal and non-fatal cardiovascular events than the untreated patients. And this included an MI and stroke. I want to say thank you very much. I know that it's so hard to summarize such a broad topic in under an hour. If you have any questions, please follow me on my social media. Go check out my educational website, beyondthepearls.net. I hope you learned something about the importance of heart and sleep apnea. I'm Dr. Raj, educating you today for a better outcome tomorrow.